Congratulations to all my friends that we are together online. The situation in Russia is rather safe time, but nevertheless, just now we are in the village house in order to escape the coronavirus. But still, on Monday and next week we are go for to our work. We are on duty, so we perform planned surgery, and only for weekends we can go out from our hospitals. But nevertheless, we are healthy and we are alive. And once more, I am happy to see my friends.
Imad, can you switch on Chandrashekar Deopujari's mic, please?
Yes, sir, done.
Okay.
Hi,
Salman.
Chandra.
Good afternoon.
Hi. Good afternoon. Good to see you, man.
Nice to see you guys. Yeah. Are we? I think both our speakers are here, so
We're all set to go. How's it in India? Everything okay?
Bombay is not. I really can't say we are okay. We are very badly locked in. Work has come to really a standstill. Apart from very bad emergencies and the COVID care itself, work has really come to a standstill. We are hoping that things are getting better for the last 3-4 days. So if that trend continues, maybe by 1st of May, we may get back to work.
Okay. Imad, also, I think you've got Adrián, Adrián's mic switched off. Can you switch it on? And then once you're starting the talk, you can mute all the mics, please. So if you can have Adrián on as well.
Okay, I'm unmuted now.
Okay, so I think I'd get Sergio to moderate this session. I'm just going to take a back seat. Sergio, would you like to invite our friends? You know who's talking. He's muted again. Can we unmute?
Yes.
Yeah. Sergio, would you like to introduce the speakers?
I am not very familiar with this program. So, and
whoever you want to go first, you tell them, please. You know, we have Sandi and Adrián to give the talk. You ask them. It's a friends session. Don't worry. We're recording this to document it just in case.
Now I'm online.
Okay. Shall we get Sandi to go first? Adrián, is that okay?
Sure. Ladies go first.
Okay. All right. Sandi, are you here? Can you hear me?
Sure. Okay. So do I share screen?
All you do is you go into share screen. Click on that.
Okay, the host has disabled me to share the screen. So
Imad, can you please allow our friend to share the screen?
Yes.
Imad,
you can share it now.
Please share now.
Okay, perfect. Share screen.
Brilliant. So we all are going to mute ourselves so that there's no disturbance during your talk. Okay.
Great. Okay. Well, thanks, everybody. I feel like I'm among friends from around the world, so this is fun. I wanted to talk about something that I think is like an interesting question. Most of the time I have studied with a lot of data and written about a lot of things, but this is kind of a surgical talk, and I'd love for you guys to give me your perspectives. So we are among friends, and we'll have different types of video, and I expect participation. So I'd like to talk about flexible endoscopy and straight endoscopy. A lot of times when we do the IFNE workshops, we're doing a lot of straight endoscopy and some very innovative things. But over the past decade, I've learned about the range of flexible endoscopy. So let's see, maybe I should get rid of this thing. Okay, so when we know about ETV, right? Endoscopic third ventriculostomy, and we know that the ETV success score actually performs quite well in terms of predicting who is going to have a good lasting outcome to surgery for hydrocephalus. So, and that is based on the age of the patient, the etiology of the hydrocephalus, and a history of previous shunt. And this was developed by our friends here from around the world and the Canadian group as well. So when you look at how that bears out, I think Imad might have.
Sandi, you have on the bottom, you have this.
There you go.
That's
Got it.
ready. That's
Okay. So so I actually looked up a chapter that I wrote about 9 years ago, and this was the way I thought about endoscopic third ventriculostomy, right? You have to have kind of a straight shot. You need your preoperative imaging. At that time, I really preferred the OI Handy Pro with a sheath and then the Fogarty balloon and a straight bugby. You can use your, spreaders, other types of instruments, and there's many ways to approach this. But we know that most groups around the world, when they report their outcomes, it generally falls in line with the ETV success score. So we know the success by age, that this will break down. The youngest patients tend to do the worst, and the older patients tend to do a lot better. So these are from actually different papers. This is from my own paper for US population-based data. This is from the Miami and Boston group looking at etiology of hydrocephalus. And when you look at the Canadian and the Israeli groups and also the European groups, it looks very similar to this. So post-hemorrhagic hydrocephalus does a little worse. The aqueductal stenosis does better. And then things kind of fall in between. Then the history of prior shunt. So if they've had a shunt before versus no shunt before. And that's from different studies as well. So there's many studies that have really looked at ETV. And then over time, ETV and choroid plexus cauterization, popularized by Dr. Worf's writings in the early 2000s, and then now studied around the world. So that's what got me interested in kind of this topic about flexible endoscopy versus straight endoscopy, or, and how that applies to ETVs and ETV CPCs. So there's a lot of kind of like bigger data types of studies that looks at how the ETV will perform. And then now, getting to be a higher impact type of studies, longer term neurocognitive outcomes published in the New England Journal of Medicine. But what kind of caught my eye and got me interested in this at first was actually looking at, in the 2000s, Dr. Worf publishing his results in myelomeningocele, and how actually a far better number for success and higher than predicted for comparing to the ETV success score, looking at the etiology of hydrocephalus, right? So if you're looking at infants, so say you're going to get a score of 0 or 10. If you look at myelomeningocele, you're going to get a score of 20. Okay, so at most you're going to have 30. And then if you've had no shunt before, at most you're going to get 40. But when you look at these survival curves, they are more like 75 to 80%. And it was reported that the success was about 78%. So when you look at other groups that have looked at how this, is it the patient population? Is it the surgeon? Is it the technique? Other people have tried to look at propensity score matched analyses and looked at, is it the endoscope, right? And this is the IFNE, so we should think, well, is it the instrument? So what I've come to think is, well, is it equipoise? Does it not matter what you use? Is it patient selection? Is it the surgeon and just picking, can you do this safely? Can you do this effectively? And are you picking the right patients? And are you setting yourself and your patient up for success? So if you don't think it's going to work, do you go to shunt right away? So from this paper, actually, I thought it was very well done, but there wasn't actually a statistically significant difference in terms of instrument. So, was it a priori because of patient selection to begin with, and that patients had shunts if surgeons didn't think it was going to work? So, is it the instrument or not? So, I'll tell you things that I've learned over time. Definitely use a scope holder if you're going to use a flexible endoscope. Don't try to hold it and operate at the same time. So I'm going to give some examples. And actually, this is a great time now to actually poll the audience. How many people use the flexible endoscope? I guess if you don't, then we're going to think that you use the straight endoscope. So how many people use the flexible endoscope? Start doing your clapping reaction or something like that.
Please raise your hands if you want to.
I can't see people raising their hands. So Salman or Adrián,
Mark, can you show us? So if you click on the participants list, then you see that then it's Dr. Rashim Kataria who's got the hands raised. So that's the only one I have had.
That's the only one. Oh my goodness.
2. Adrián says he does.
Okay. Well, great.
Well. It's only 2.
All right. Well, don't judge. No. So I used to be like exclusively a rigid endoscope, and then I actually I go to Kenya every year, and then now Uganda too. So that's when I started to see that there might be a kind of a different approach. My personal theory is that it is just a completely different surgery. Nobody's written that. I invite anybody to write that with me. That's my theory, that actually I just think it's a different surgery, and I'll show you why. So for myelomeningocele, how many people are doing ETV and how many people are going straight to shunt?
So people who are doing ETV first, can you raise your hands, please? So I have 1, 2, 3, 4, 5, 6, 7.
All right. Well,
7.
All right. So, I will kind of show some examples now, and probably for each case, it'd be great to get some polling to see if you guys would actually just go straight to shunt or if you would use endoscopy. So, so I've moved to using flexible endoscopy for all myelomeningoceles. Actually, for most of my cases for hydrocephalus, and I'll show you why. So especially for myelomeningocele, you'll see that the floor of the third tends to be kind of thick, and the anatomy is quite tight in the prepontine cistern. So also there's usually an interthalamic adhesion. So those areas are rather difficult to navigate, especially with a rigid endoscope. So I think there's a rationale for the flexible scope. So here we're dropping in to the lateral ventricles. You'll see there's really not much of a septum. This is going into the foramen of Monroe. You'll see that kind of funny bump that you have to kind of navigate over. That's looking backwards into the aqueduct, and then you'll kind of then you'll see this is more familiar anatomy, right? The infundibulum. I never connect the bug bee to power when I'm in this area. I make sure it's actually just a blunt instrument. And this is a trick that I learned actually from my colleague who trained in South Africa. and is at Cure, Uganda now. So you actually use the bug bee, and then you follow it with the flexible endoscope, and you actually twist it. You kind of like twist and follow and kind of like thread your endoscope over the bug bee. Then you'll just kind of be able to follow it over time. And you hold the endoscope like a pencil with a holder. And for the myelomeningocele, there tends to be these kind of like webs, you know, or a lot of adhesions in this prepontine area. You just kind of have to take your time. The basilar artery is right there, which is why I never have the bug bee connected to power here. And I just use that kind of as a blunt dissection instrument. And you just kind of have to navigate between these kind of arachnoid adhesions, and also make sure that Lilliquist is open both in kind of the horizontal and the vertical aspect. I'm never done until I see upper cervical rootlets and cranial nerves, then this naked vertebral artery, the basilar artery. You'll see that kind of vertical aspect of Lilliquist is open. And then see if you are CSF, you're now flowing widely, right, across the subarachnoid spaces. And then that would be Lilliquist, and that's the dorsum sella, and then that is the floor of the third. And there's usually that kind of thick tissue right there in a myelomeningocele patient as well. And then now onto the CPC part. So I'm looking at the choroid plexus. I typically go in the back first, and I leave the area towards the foramen magnum at the very end, because that might have the potential to have some friable vessels. So yeah, that's the way I have really completely changed my practice now. For doing neuroendoscopy for hydrocephalus in kids, and in kind of global learning. This was not something I learned in training. I actually learned it in Kenya, in Kijabe, when I worked with Emmanuel Wagoye, who's now at Cure in Uganda. So that really just kind of fundamentally changed my practice about 5 years ago. So that's why I think when we're reading the papers, it's difficult to interpret, is it really the instrument, is it patient selection, or really is it like an entirely different type of operation? So onto different types of cases. This is kind of more a younger patient with obstructive hydrocephalus. You'll see that kind of little aqueductal stenosis area. And this would be, now this, courtesy of my group and my partners, is a straight scope. We have different types of scopes that we use at Lurie Children's in Chicago. This is a channel scope. The optics are not quite as nice and bright, but it's very ergonomic. It's nice and straight, so the orientation is really just kind of orthogonal, and you look straight in. Then you'll see this dura again, right? So the clivus, and then you'll see the Lilliquist, which you have to kind of puncture as well. And here my partner Art DePatri generated this video. So he did that with the endoscope, right? Actually went through that extra membrane there. So that is, I think that is very practical when you need to make one hole and you don't need to really go any further. And this was not a patient that we expected a lot of adhesions. All right, that's, okay. So, all right. Okay, now we're gonna have like actually one case, two ways, where there are gonna be two posterior fossa cyst cases that are gonna be handled a little bit differently. So I'm going to actually poll the audience now and say, when you see something like this, I mean, it kind of looks like there's like a cyst in the fourth ventricle, right? The aqueduct is open at foramen of Majandi. It looks like right here that there's a little change, right, in the fluid signal. So, so for this, would the audience tend to shunt or think about an ETV or do something from posteriorly, or?
So if you think you would like to do a shunt here, then thumbs up. If ETV, then you can clap. Otherwise, if nothing, then that means you're not going to do anything. Go on now. So for shunt, we have thumbs up, and for ETV, we have clap. How about Henry? Henry, what would you have done? Can we switch on Henry here? He's keeping quiet here.
I would do an Hydrocephalus. I don't see a cyst. So I would do a cyst sequence to see exactly, is it a cyst or is it just a dilation of all four ventricles? Because the aqueduct is very wide open.
Yep, I'm
Do
trying
you
to
have
look
a
at my screen.
cyst sequence?
Yeah, I don't have it in the slides, but yeah. So right here, if I could show you with my cursor, do you
Looks
see
like
right, right there? All right, but yeah, there's a little web there. You'll actually see it in the video. So yeah, and it tends to be more straightforward when the floor of the third is kind of nice and thin. Where you can see that the mammillary bodies are nice, and then so that's kind of prepping for the ETV, but then actually kind of saying, well, the aqueduct is kind of big, so why don't we look in there, and then you'll believe, yeah, so you see it looks like actually that the bottom of the fourth looks kind of like a cyst, and it's a little bit closed off right there. And then at this point, yeah, so there's a little obstruction there. So then seems like an ETV would actually kind of take care of the issue. So all right.
So Sandy, majority of the people who replied also wanted to do an ETV. We had only one person thinking of a shunt. Otherwise, everybody else has suggested ETV for this case.
Perfect. Sorry, my screen keeps on getting kicked off. Okay, so that was kind of a more straightforward, okay, ETV. Then let's see, there was another posterior fossa cyst, and these are, this is actually a similar case, and Henry, if I could show you the cysts, the CISS sequence, there's actually a little web there as well. So now if I can advance my slide, there you go. I will show you this video. So this is, okay, so mammillary bodies. And then there's this, this area becomes a little bit difficult to navigate, but the aqueduct is wide open, and this is the flexible scope. And then there's actually a cyst wall right at the end of the aqueduct. I guess I could have done an ETV at that point and said, well, there's a cyst in the fourth ventricle and ETV is going to be great. But I guess I couldn't resist. So there's, so now we made a hole in the top part of the cyst in the fourth ventricle. And then we really had a really nice view. And then here you can actually see the back of the brainstem. You can see the dura kind of through that little arachnoid area. And it looks like the CSF is pulsating a little bit better. So I tried to make the cyst wall just a little bit tighter, right up against the bone and the dura and nowhere near the brainstem. And then really made a bigger hole so that now at the outlet of the fourth ventricle, it had a hole as well. And then now you can see the cyst is collapsing. So I left that there with the cyst fenestrated all the way around in a collapsed cyst. And then now looking at the floor of the third ventricle and kind of, trying to pick where to go. And you can see that the top of the basilar is actually quite prominent right there. So we had to kind of pick an area. And then same technique, the bug bee not connected to power and kind of just leading the way and then kind of twisting the camera to kind of follow until we can see a naked basilar artery. And the naked vertebral cranial nerves are good to see. And then you can see everything looks, very kind of opened up, quite a lot of scarring. So I think if I did like a traditional kind of straight endoscopy ETV, this area would not really have had good CSF flow for the pathways, right? But now you can see, now you can actually see the clivus and then CSF pathways are open here. So post-hemorrhagic, so this was something where a decade ago I would have shunted actually, because I think in a baby that was most likely a premature neonate with post-hemorrhagic hydrocephalus, I thought that the ETV success score would be too low for me to want to offer an ETV or an ETV CPC. You can see this patient actually has an Ommaya reservoir and some porencephaly from the history of the neonatal hemorrhage, and then now has hydrocephalus. So how many people would go straight to shunt? At any reaction, clapping or thumbs up is fine for straight to shunt. And then I can't see you guys, so Salman's gonna have to tell me.
So if you click on the, if you just click on the participants, you should be able to see how many. Barbara is the only one who's raised her hand.
Oh yeah, okay. Okay, so yeah, so this patient, because there's an Ommaya in place, is now just at 6 months of age for calendar age. So, I told the family, we calculated the ETV success score, said, it's not amazingly high chances, but also, but likely worth the chance at being shunt free, right? So this is what that video looks like. Really for post-hemorrhagic cases, a lot of patience is needed. So this septum already kind of looks blown out from this chronic hydrocephalus, and the brain isn't quite normal here. So kind of threading this flexible endoscope in, and you'll see from the images that the images are turned sometimes, because I do tend to twist the endoscope quite a lot. So I actually don't try to adjust the tip and drive the camera around to make that J tip. And then there's the aqueduct, then there's the pineal area. Now there's the floor of the third, and you see all that hemosiderin staining, right? So, and the floor is not quite as thin as some of the other cases. And same thing, right after I get that bug bee in, I kind of twist the endoscope in and kind of follow. And you can, and even on the preoperative MRI, it looks like it was kind of going to be little bit tight quarters here. But once you cannulate into the ventricles, that when you have a little bit of CSF egress, it really does, it can open up a little bit. You'll see here, I end up dissecting more with the bug beat in this type of case because you can see hemosiderin everywhere, right? So a lot of hemosiderin, a lot of these little adhesions. But you know, if I'm trying to give this child a chance, like the best chance I can at trying to be shunt free, I'm trying to break up all of these adhesions and give a good CSF pathway. So these are the cranial nerves. I'm kind of still looking around for other adhesions. Here's another adhesion. Sometimes if you can't quite tell, you can use a pulse of irrigation just to kind of see how mobile it is. And I usually try to kind of do that right against the clivus if possible, or somewhere where I know the cranial nerve and the clivus is kind of holding that little arachnoid web up. And see, the more I poke, the more you see that these little adhesion areas are actually more and more mobile with the cardiac cycles. So somebody had a lot of patience to talk me through these cases and teach me, and I'm very grateful. And that's the dorsum sella there. And then the hole is actually pretty good when we're backing out. And then going into the CPC type area now. So the biggest tip I learned is that you have to kind of keep on moving, because if you get stuck to the choroid plexus, it's difficult to recover from. And really, when you're using a flexible endoscope, your working channels, your working portals are not very big. So let me see. All right. Sorry. Okay. How many people can I get kind of like some feedback for, like, is that like a typical flexible ETV CPC that most people do, or do you think that's a little on the aggressive end?
Okay, people who, you know, you can write on the chat if you think it's aggressive, or is that what everybody would do? So Alessandro is saying that I don't see bubbles on the tip of your instrument.
You don't see what?
Bubbles on the tip of your instrument. Yeah.
Oh, yeah. So so when I need continuous irrigation, I will. Otherwise, I have I do a syringe irrigation in that system, and I just pulse irrigate when I need to see something or clear something.
Okay,
so
Henry is suggesting a septostomy.
Oh, yes. So that child actually had no septum when we went in, so we could actually just see the right and the left side. If the septum were present, I would do a septostomy so that I could do choroid plexus cauterization on both sides. But since there was already none, I could just do the choroid plexus cauterization on both sides. So this, another one. So this is actually a congenital asymmetry of the.
Sorry, Sandy, we are 35 minutes into the talk, so we need to cut short so that everybody gets a chance.
Okay, great. This was the last case. So yeah, just kind of various various types of applications. I'll actually show you the kind of. So this is kind of my conclusion. You can use the instruments and you can do shunt at any time. But and there's copious literature, but I would say choose the best strategy for your patient, and then choose the best strategy for your practice. And then I think we should kind of develop that literature and the understanding together. So thank you.
Brilliant, Sandy. That was an excellent talk. I would get comments from Pepe. Would you like to say something? You're on.
Yes, thank you, Sandy. Good morning, Sandy. Fantastic talk, very nice. About your first case with the cyst in the posterior fossa, in fact, I shared the same doubt about the fact that there was a cyst inside the foreventricle. It was because when you, in fact, I had some doubt because it was looking like a tetraventricular form of obstructive hydrocephalus. And in fact, when you enter through the aqueduct, we had the feeling that there was no membrane inside the aqueduct. So you just enter through the aqueduct inside the free foreventricle that was obstructed due to closure of Magendie and the Luschka foramen.
Yeah.
And,
I agree completely, Sam. That's what I mean and meant, that there is no cyst, it's just a tetraventricular hydrocephalus, and ETV is a procedure of choice.
okay, sure. Yeah, I agree with that. And also the second case also was very interesting because I had the feeling really that it was a sort of Dandy Walker variant, but on the MRI. But in fact, when you entered through the aqueduct, there was a clear cyst membrane just below the aqueduct. Very interesting case. And certainly this was not a Dandy Walker because anatomically you don't find the membrane below the aqueduct, but it's a very interesting form of cyst inside the fourth ventricle and the megacisterna magna. Very interesting case. Thank you.
Thank you.
Thank you, Sandy. Could you undo the share screen? It's on the top.
Oh, stop share. Got it.
Yeah. There's a question about comment regarding water dissection versus negotiation of the scope in the basal cisterns.
I missed the first part of the question.
Water dissection.
Water dissection.
Yeah.
Yes. So so that's why I use a syringe of lactated ringers connected to my system, and I actually do kind of like a pulse irrigation, so it can help it in a water dissection kind of way. It'll show me where I need to do that bug bee dissection next if I need to, but sometimes just that pulse of irrigation, like a water dissection, will help open things up already.
Hello. Hello, can you hear me?
Yes, we can hear you.
Yep.
Yeah, fine. So thank you, Sandy. That was brilliant. I must tell everybody this is actually a joint session of IFNE and WFNS Endoscopy Committee and Pakistan Society of Neurosurgeons, and I'm grateful to everybody for tuning in. And we have 170 participants, which is brilliant. And next we have Adrián, and he's going to be talking about complication avoidance in endoscopy. So you can share the screen.
So, okay, I'm going to share my screen now. Okay, let's see. Okay, so you can see my screen?
Yeah, brilliant.
Okay, all right, let's go to slideshow. So as you just mentioned, this is a conjoined session from all of these instances, and I really would like to thank everyone from far and near for attending this session. So let's go on. Oh, hold on, let me see. Okay. Are you seeing my slide?
Yes.
And do you see any images aside from the text?
We see the text.
But no images? You don't see any images?
We see the text.
But no images, right? That's weird because here in my screen.
Okay.
Okay, hold on a minute. Let me load the talk again, just to see what's going on. Go for me for a second. Okay, let's see what's going on here. perhaps you can discuss a minute while I put it up again.
Okay. So anybody wants to ask a question can raise their hands and we can just switch everything on. So Alonso wants to say something. So let's get him up here.
Hello, good morning from Chile. Thank you very much for this instance. I want to share with you my little experience. I started with the neuroendoscopy at the ends of the 90s. At those times, the difference in the quality of visual optics were tremendous, were extremely great. And that's why we choose to follow our experience only with rigid scopes. So I want to ask now, Dr. Sandi, nowadays, the equipment and the quality of visual definition are the same. For example, for instance, to do the cauterization of the choroid plexus with flexible endoscopes. Thank you.
Thank you. I agree. The flexible endoscope, actually, the newer generation is a digital image. It's beautiful, but it's actually less flexible. So in order to twist into the temporal horn, sometimes it is ergonomically very challenging, and that part is lacking. The older fiber optic scope actually has much more flexibility. So you get what you gain in image quality, you actually lose in flexibility. So it's a little bit of a trade-off, and you have to kind of pick which one you want to use. So I like both, depending on I pick depending on the case. But there is that trade-off.
Brilliant. Now we can see the picture that you wanted to show. It's there, Adrián.
Okay. Yes. So all the images are loaded. So
Brilliant.
let's go ahead. So whenever we talk about complications, we need to come up with a definition, right? So a surgical complication is defined as an undesirable, unintended, and the direct result of an operation which affects the patient, and that would not have occurred had the operation gone well. And the definition is very wide if you search through the literature, because you can have an abnormal scarring of a wound, you can have a CSF fistula, you can have big-time intraventricular bleeding, permanent neurological disability, and you can even have death. So it's a very wide definition. Pepe Shinali came up in 2007 with this classification for the outcomes of neuroendoscopy. So if everything goes well, then we label it as a success, as a partial success, whenever the primary objective is accomplished. But you required something else. You had to place an EVD, you had to coagulate something that was bleeding, but essentially the case went fine. There is success, but then you need to reoperate for the primary objective because you had to leave and then come back, and then the complete failure. So this scheme that we're looking here is basically a model that has been postulated for many disciplines, and it's basically what they call the Swiss cheese model. As you can see, there are several barriers. There's organizational influences, there's supervisions, there are preconditions, and then there are acts. And sometimes, whenever in these four barriers, all these holes line up, then things happen, and you end up with a complication. So no matter what, sometimes even in the best prepared of scenarios, with the best patient, with everything going well, something will happen that can lead to a complication. It's a combination of things. So I guess everybody here who is watching would say, okay, so how can we avoid complications in this setting? And I think the main issue is that as we gain experience in endoscopy, as in anything else in surgery and medicine, you basically have to have a very open mind and to consider that there is always a point of no return. There's always a point where you go too far, and if something goes wrong, then essentially things are going to go bad. So you always need to be very aware that there's this point of no return, and that if for whatever reason you feel it is unsafe, or you think it's harmful to the patient and you have a better alternative, then you should leave it alone. So what is the definition of an extreme decision? So when do you abort the procedure? Well, that's defined as an unplanned cessation of a surgical procedure prior to the pre-planned goals. And as I said, it's sometimes aborting a procedure is not a good thing, but in terms of your pride, but it's a good thing for the patient, because you're always trying to make the best decision in order to protect function. So this paper just came out. I highly invite everyone to review it. It was published by the Israeli people from Tel Aviv, from Jonathan and Shlomi. And it's looking at the factors that lead to aborting an endoscopic procedure. Look at here. I am basically dilating membranes in a patient who had an arachnoiditis. I've already gone through the floor of the third ventricle, and I'm dealing away with all this scarring tissue. So sometimes you might say, am I doing too much? Is this patient really gonna have good CSF flow if all the subarachnoid space is pretty much looking like this? Do I have a better alternative? While doing this, can I harm the patient? So all of these are valid questions that you should always have in mind and say, okay, maybe this is not gonna work well, and perhaps this is the time to leave and convert this to a shunt. Also, look at this case. This is a patient who had an intraventricular metastasis. This is some of the things that make recording imaging very useful. I'm looking at a case that we did several years ago. And just because the fact that you have an endoscope at hand does not give you a free right to do whatever you want within the ventricular cavity. I successfully removed this metastasis in the intermammillary space. And then you realize you're flirting with disaster. Hopefully, nothing will go wrong. But I think these images and what we're looking here is basically that you shouldn't get too cavalier. In this particular case, we already had to take out later on the posterior fossa tumor. So you might ask yourself, why bothering flirting with disaster if you're going to come later to get the full biopsy? And perhaps, as sometimes happens in my department, you take these tiny biopsies and the pathologist is not going to be able to make a whole lot. So if you can have a safer choice, go after that. So which means that if you have an endoscope, not everything has to be done endoscopically. You should always consider that there are safer alternatives. And in that very same paper, Shlomi looked at this and said, okay, so here are some things that go from shifting the scale to an ETB or against an ETB. And most importantly, look at the reasons that are very valid in order to stop a procedure. So if you have distractions from your judgment, if you think that the procedure is possible with an acceptable risk, if you feel that aborting the surgery is a professional and personal failure, or you are having appropriate self-confidence, free of colleagues, and so on. All of these things can tamper with your judgment and get in the way of aborting a procedure. But you should always remember that as we gain experience, we come to be what I call a well-seasoned surgeon, is an expert. And why is that? Because an expert is that surgeon who has experienced or witnessed in the hands of someone else every possible complication related to a procedure, and who also has learned how to deal with these complications but most importantly has learned how to avoid it, and now is capable of preventing others from reproducing such complications. And in this, I think there's a lot of value, because sometimes we attend seminars and see conferences, and everybody comes out with their nicest cases. But I think we have to be humble enough, and you have to also show people from the things that have not gone so well. So look at this. This is the traditional learning curve. As you can see here, usually you think that things have a slow beginning, then the term that there's a steep curve implies that perhaps you'll find some tough cases, but you will be able to climb, and then you'll come to a plateau. So, but the thing is, experience comes from practice, and people who have highly skilled practices, such as airplane pilots and musicians, practice for a lot of time. And endoscopy and surgery is sometimes quite the opposite, because while an airplane pilot is sitting in a simulator for several hours, or a musician, you're only within the ventricular system for a few minutes. So in order to accumulate this experience, it takes a lot. We have devised several devices in order to try to replicate, but still we face those challenges in really teaching how it feels to be within the ventricular system. What's the feeling of performing this? And look at this. This is the comparison of risk in healthcare as opposed to other industries, and you will see that we are basically right there with bungee jumping. So the procedures that we do are quite risky in terms of what can go wrong. And this concept of the learning curve was actually described by this man, T.P. Wright. He basically was describing that initially you take a bunch of hours to produce an airplane, a military airplane or military device, and that as time goes by and you get more experience, you're able to reduce the time in order to produce that same device. But this is hardly applicable to medicine. Look, this is basically what we have now come to define as the learning curve. Initially in this phase, in phase A, you start doing cases, and then you come to an acceptable standard, and then you reach point B, and then you'll see a little dip in the curve. And that's the dip that whenever you're doing a lot of cases, you start bumping into unwanted outcomes. And that can slow you down, that can actually modify. And this is, I think, the most valuable part of the curve, because you start learning how to avoid the procedures. And then you gradually move on to the latter part, which is a good outcome. And here in D, that's when you're in your prime as a surgeon. And E, well, as we all age, and sometimes our capabilities start fading away, so you start to decline. And as any good boxer should do it, then that's the time to retire. So how do we measure outcomes? Well, sometimes it's basically the length of stay, the analgesia, the morbidity, the mortality, and the survival rates. But the outcome measures for surgery are based on the operative time, the use of equipments, consumables, the cost of all these equipment, the blood loss, radiation exposure, and so on. And it's very important that you should always have an ongoing awareness of what's happening within the operating room and within the procedure. What's the level of risk? What's the availability of time? And based on that, you can come with 4 kinds of decisions. Sometimes they're intuitive, sometimes they're rule-based, sometimes you analyze the situation in that moment, and then you choose from the best possible outcome. And sometimes you get creative. So we have maybe we have used this phrase for, it has become a tradition to say, to be or not to be, whether that's the choice. So you should always remember that you can be the one who's asking the question, but yes, this can be your patient, the patient who's already on the other side. So whenever you take any chance, you should always consider that it's not taking you who's taking the risk but the patient. So this is the typical picture of someone doing an ETB. This is an ETB doing at our institution. Look, this is a beautiful exposure of the basal cisterns. But how can I teach anyone of what's the feeling of performing this procedure? How hard should they inflate this balloon? What is the feeling of perforating the third ventricle? These are the things that are thought very tough to teach others. This is also a transfemoral procedure, and they're drilling away. So how can you teach people if not by letting them do the procedure and then taking the acceptable risk of having an unwanted outcome? Learning how to drill and have this eggshell thin bone can be, very tough. It's just by learning that you actually, by doing the procedure, that you will learn, and sometimes things go wrong. So we'll come back later to this unfortunate case. So, and there's always the discussion of whether there's an indication that's valid. I have engaged many times with some other colleagues. As you can see here, this is the typical dilated structure that you can see here in the third ventricle. It's basically a Kaplan-Bergei that's causing headaches in a patient. And I would like to see a show of hands to see who would say that this is something that should be operated, and so this is something that should be left alone. So I would like to listen first the opinion of, let's say, Pepe. Pepe, are you there in the audience? What do you think about this?
Let's get Pepe in here and unmute him so that he can. Yeah, Pepe, you're on.
Yes, I am. We had the same discussion in the last webinar. Depends very, very much on the symptoms. If the symptoms are very suggestive of a headache, positional headache, or invalidating headache, then I would go straight. Henry thinks exactly the different opposite, but I feel that headache is very strong. I have very good success rate in headache management by treating these patients.
Okay.
Okay, anybody else who wants to comment on this?
Is Shlomi there? Or Jonathan?
Good morning, everybody.
Hi, Sulma.
Hi. I had several cases of this, and some of them, when they don't have symptoms, I just watch them. But I at the same time, I have the feeling that I'm sitting on a bomb time. And most of the times I have the tendency to offer the family fenestration before we go into an emergency surgery. So that's my tendency.
Okay, so as most of you know, there's discrepancy of whether you should manage this endoscopically or whether you should leave it alone. I have in the past engaged many times with Shlomi, and he has told me he's got a series of patients that eventually, with just careful watching, patients did well and went asymptomatic after a period of time. Myself, I like to fenestrate, but you should always be mindful that there are some indications that you should always analyze very carefully. This is also some of the data that has come out recently. As you know, now we're very keen to coagulate the choroid plexus, and look at the number of cases that have increased over the last few years. We don't know yet whether this coagulation of the choroid plexus has an impact in development. The choroid plexus probably sits there for more than just the reason of producing CSF. There are many substances produced by the choroid plexus. So we'll have to see in the future whether, coagulating is a valid measure. And as always, there are things that become a trend and then they later fade on. This is the graph from the Nazi studies. And as you know, when we were trained, we were told that everybody should get methylprednisolone. Then it went away, and then it gradually picked back again. So things are changing. Now, the other thing that you should be mindful is that a shunt is not the devil. A shunt sometimes can always be a good procedure. And Sometimes converting into a shunt is a wise decision. Sometimes using a shunt is a good decision. But also a shunt has its complications as well as endoscopy. So there's always, this balance in between the two procedures. So overall, from 6 to 20% has been quoted as a complication rate for endoscopy. I think one of the problems is that people do not tend to report all the complications. The global rate is 8.5%. 4% of them lead to a procedure termination. 3.7 involve hemorrhage. And the most feared complication of endoscopy, which is the basilar artery lesion, it's actually less than 1%. And also less than 1% permanent neurologic sequelae, at least on what has been written. As you know, this Latin aphorism of errare humanum est means that it is human to commit mistakes, but very often we do not cite the other portion of this phrase, which is perseverare autem diabolicum, which means, but to persist doing it, that's what's really wrong. So we should always be mindful of that. So what are the contributing factors for having complications? Well, one of them is inexperience or malpractice. Sometimes you come in late at night and you have a non-neurosurgical scrub nurse who knows nothing about the equipment. Sometimes many cases have been done through the day, and then you don't have all the available equipments. Sometimes the optics or the monitors are not working right. Things can, it's an electrical device which can malfunction. The position of the endoscopic tower, the position of the patient, the type of endoscope holder, many of these things will affect your outcome. So always come up with a protocol, and we have already come up with some data to determine what are the best indications and these algorithms for performing ETB. But always prep for plan B. You should always have in mind that when you're prepping the patient and you're setting up the case, that you might end up doing a shunt, or if you're doing a tumoral sample, you might end up converting this to open. So are you familiar with the case? Are you familiar with the technique? Do you have the images at hand? If you have a navigation for all, please use it. Also be mindful that any fluid that you're putting into the ventricle has to come out, and that irrigating solutions should be at room temperature. Test all electronic equipment prior to the incision, please. Every single scissor and forceps should be opened and closed before you put it into the patient, just to make sure that it's going to work right. You will be surprised. You will think that everything is working tip-top, and then sooner or later you will come to the point where a forceps got stuck or scissors would not open and you're grasping a delicate structure. So be mindful of all of this. So when you insert the scope into the patient, you can do it either using a ventricular catheter, you can use a trocar, and always be mindful of the depth guides. These are very important as a rule of thumb, as whenever we're putting in shunts. Nothing that goes below, farther than 5 centimeters, you should reach the ventricle always. This is the reasons why even endoscopes have all these depth marks that you should be mindful. As I said, if you have neuroavigation, you should use it. Sometimes you can rotate the scope during the insertion. And remember, a borehole it's just a tiny window into a big universe. So you have very little control of what happens below that little hole. So very important. Are you seeing the real thing? This might sound a very weird question, but Charlie Teo told me many years ago about a case of someone who was doing an endoscopy, and for whatever reason, back in the day, somebody put in a pass procedure, and it was almost exactly at the point when they had started doing the same case. So the surgeon was confounded because he was looking at the screen at an ongoing case, and he thought he was doing the case, but it didn't make any sense, and of course things went very bad. Is the camera oriented in the right position, or is what is up is really up in your endoscope? Is the system well coupled? Sometimes lenses can be foggy, or they can be damaged and can prevent you from having a good image. There can be blood deposit or brain debris, or you can have ventricular, so hemorrhage. So this is one of the operating room setups that we use in order to have both surgeon and assistant with a good view. This is something that originated in the transsphenoidal procedures, but now we do it for neuroendoscopy too. And also always plan your point of entry. As you know, Stefan Wolfsberger has already described this technique in which you basically map out where is the anterior portion of the foramen row, the posterior portion, and then you basically draw a triangle that leads you into your target, and you basically put your burr hole in the middle of those two trajectories. Sometimes you're doing endoscopy, you're ready for the case, you come into the ventricle, and boom, you find out that your trocar has produced bleeding, and now things are really shady and things are not looking well. Sometimes you're doing a procedure and then you start seeing all this blood that's coming from the piercing of the ventricular wall up and above. And if for whatever reason things get too shady, you should always think about aborting the case. Sometimes you're doing an endoscopy and particles of brain debris from perforating the ventricle get in the way. You finally manage to either flush them out or remove it with a forceps, or remove the lens from the cannula and go back in and try to wash it out and see whether that is going now out of your way, and then you can look properly into the ventricle. You're coming in, and for any given reason, the little particles start showing up again. So always be mindful that these are things that can happen. And sometimes you're trying to take a bite out of a tumor. You know that if you coagulate it, the pathologist will say that this is no good, and then you take a bite, and this is what happens. So intraoperative complications, 20% of the patients will have tachycardia, 9% will have tachycardia with hypertension, 12% can develop bradycardia, and hypertension with brady or tachycardia just in 9%. Most of the time, these are transient things. I like to listen all the time at the EKG machine. That beep tells me what's going on, and I'm always in good communication with the anesthesiologist. Also, if you have a navigating system, you should always use it. It will guide you and will provide a lot of interaction as you're going into the ventricle. And of course, you should always review anatomy, whether you're coming from below or from above, into all this very particular anatomical area, which is the sella. And you should be mindful of all the structures that are sitting below the floor of the third ventricle. All these great anatomic illustrations will give you insight of all the structures that you might find. But you should always also remember something, that disease never studied anatomy. And there is a high chance that your patient will never look like the beautiful illustrations that we all learned on the netter. Once you're in there, things look very weird. Look at this third ventricle in a patient with myelomeningocele. The floor is completely atypical, and we have interthalamic and hypothalamic adhesions, which can range in various sizes to become enormous. And sometimes doing procedures and doing ETBs within these structures can actually can be very challenging because these things get in the way. We know now that if for whatever reason you're doing an ETB and some of these hypothalamic structure starts to bleed, you can actually coagulate it, and most of the time there's no major complication from doing so. So nowadays, MRI has provided with beautiful views which should help you to plan your trajectory into the anterior cisterns. And look at this case. Even this is a case that was from a few weeks ago. This patient came in, had a big-time hydrocephalus. He was previously shunted, and now he was in dire straits. And you can see from the CAT scan, because the patient was too ill to undergo an MRI, you could tell that the bacillary artery was a little bit in the middle of the cistern. So when we went in, we already knew that things would not be normal, and you can see here a pulsation, that it's high riding. So we decided to go and perforate the floor of the third in front of that high-riding basilar artery. And as you can see, because of the pattern of these, sometimes you cannot see directly straight down. But we were successful in dilating the floor of the third. I'm going to speed up this in the sake of time. But you can see how the artery was basically high-riding the floor of the third ventricle. So you should be always mindful that careful planning is a must for every single case. So myelomeningocele, subarachnoid space tumors, multiloculated hydrocephalus, thalamic and hypothalamic tumors can always present you with several challenges for performing endoscopy. Look at this other case. This is a patient with long-standing hydrocephalus. He already had a ventriculitis many years ago, and it's almost impossible to tell which structures. I just went through the foramen of Monroe. We are looking at the floor of the third ventricle. It's very hard to tell which is which and what is what. But if you're using navigation, this can clearly show you the way. And as you can see there is a hint of the mammillary bodies. I'm just going to speed up. And because of that hint, now we know that probably the triangle described by Deck is anterior to this. So we proceeded to fenestrate in this area very carefully using the Fogarty balloon, which has a blunt tip, and slowly you start dilating the floor of the third. Surprisingly enough, this case, even though he had all this carrying in the intraventricular structures in subarachnoid space, actually did very well. But these are tough cases. This is not the case you want to start with. And if for whatever reason, when you're doing these kind of cases, you feel uncomfortable, you feel you're not prepared, and you feel that perhaps you're going too far, then you should abort and convert this to a typical shunt case. As I said before, a shunt is not always the devil, but these are things that you gain by experience. Okay, so one of the most common complications in endoscopy is basically bleeding into the ventricular cavities. So we're looking here, another myelomeningocele patient. We went ahead and performed an ETB anterior to that interhypothalamic adhesion. And you can see here that as I deflate the balloon, you start getting some bleeding, just so you basically re-inflate it again and you hold it for a little while. You can start irrigating. Sometimes just by holding the balloon, you can see that some of these tiny vessels will stop bleeding. In this particular case, we could see that the blood somehow looked like venous blood, and as we deflated the balloon, we started having some bleeding again. Therefore, we basically removed very carefully the balloon after inflating it for a little longer. And this is just a resume of the whole video. But since we were unsuccessful, we proceeded to irrigate the area. And after 3 minutes of irrigating with saline, the bleeding stopped. So most of the time, these tiny bleeders, which are venous, will stop just by irrigating. Sometimes they will need a little coagulation, but that will do the trick. This is the working channel technique that was initially described by Henry, and this is the baby Lotta endoscope. I'm just showing you that you can actually use the sheath of the endoscope as a working channel to perform dilation of the floor of the third ventricle with your balloon. So now, having that technique into mind, you can actually use it whenever you have bleeding. In this case, this vessel has been cut and now you have hemorrhage. So you get close to the area of bleeding, you keep irrigating, and with that endoscopic sheet, you try to isolate the area of bleeding while you're irrigating. I know this is tough, and that the natural thing would be immediately to retract. So always remember, keep your scope in place, keep irrigating, and now you have isolated the point of bleeding just within the sheath of the endoscope. The blood is not being mixed with the whole CSF. And through this, you can actually, if you have patience and nerve, you're able to coagulate that tiny vessel that was giving you some problems. And this is a very useful technique for bailing out of very focal bleeding when it comes from minor bleeders. Also, we have mentioned previously that sometimes you're working in a space. This is, again, the case of a tumor that we're biopsying, and we know that if we coagulate too much, then the biopsy will be unusual, and then you start getting bleeding. And sometimes you irrigate and things do not get better. But if you convert to this dry field technique and you suck out the CSF, you'll see that sometimes that bleeding was actually not that huge, but since it was being mixed with the CSF, that prevented you from seeing well. And most of the times, these patients do very well. As you have seen from Sandi, we always like to peek within the structures within the anterior cistern, and we poke with your endoscope into these structures. But sometimes, whenever we're doing these procedures, we'll run into the most feared complication, which is hurting the basilar artery. This is a video that was shared by Dr. Chandrashekar. I really thank him for sharing his expertise, not only on good things, but things that sometimes go wrong. As you can see, this is a patient who previously had a shunt, and he's proceeding to open the floor of the third ventricle. He's choosing the best place in order to pierce the floor with the Fogarty balloon. So he moves away from the bifurcation of the basilar artery. He dilates the structures. And as you can see here, now he's got a nice hole. And now he's ready to look into the basal cisterns. He's advancing. And perhaps this is one of the big differences between what Sandi has shown us and what happens with rigid endoscopy. Now we're looking into the basal cisterns, we're looking into the arachnoid, and you're looking to one place, and you're looking to the other side. And in doing so, you're trying to open space in order to let CSF flow properly. But as you're going deep down, you should always be mindful that you're pushing structures around with your rigid endoscope. And as he is retracting his scope from the subarachnoid space, trying to open, you will see the point. Look, there are some cervical rootlets. That's the basilar artery. He's retracting away, and all of a sudden you start seeing, this massive bleeding. This is another video. This is coming from the Tel Aviv group. This is Shlomi. Again, they pierce the floor of the third with the blunt monopolar, and he goes into the basal cistern. As you can see, there are vessels protruding. You're in there. There are several structures, and you start trying to make up some space with the Buckby wire, such as how Sandi was showing us. And all of a sudden, while you're trying to make some extra space, then you encounter a point where there's major bleeding. So very tough. I think most of us are very afraid of this complication. This is another video shown by Kenichi. He's trying to make some extra space, and look, again, this is major bleeding, the basilar artery. So always be mindful that the tip of the endoscopes can have sharp edges, and here in the lower left, you will see that sometimes even angle lengths protrude and have sharp edges that can actually hurt vessels as you are going down within the artery. This is a slowed still motion. So you should always be mindful that even blunt instruments such as that Buckby wire can actually injure the basilar artery. We'll come back again to that later on. This is the post-TTV morbidity. So 1.44, you can have neurological morbidity. You can have oculomotor paralysis when you're blowing up that balloon and you hurt some of the third nerve that it's lying underneath, the floor of the third. You can have consciousness disorder, hemiparesis, memory deficits. And you should always remember that you can also have endocrinological morbidity. And this comes basically from the fact that you're coagulating or piercing very close to the stalk of the pituitary gland. So as you're coming through this area, you're basically navigating through a lot of critical structures. Some patients develop diabetes insipidus. 2/3 of them are transitory, 1/3 is permanent. And of course, they can behave exactly as with any other kind of cell procedure. You can have a immediate DI, you can have a transient improvement and have a triphasic response. This is a video shared by Hakan Karabagli from Turkey. Sometimes as you dilate with the Fogarty, your hole was well placed, but as you deflate, you can see here that you were really, really close to the stalk. And these tiny vessels sometimes don't like all that manipulation. You can go on to have all these deficits. Other complications, hygromas after third ventriculostomy. As you know, whenever you're doing a third ventriculostomy, you're not doing just one hole, but two, one through the cortex and one below. So sometimes fluid can come out through this hole, and it has been said that all to 1/4 of children lesser than 1 year of age can develop hygromas because of skull-brain disproportion, because of abrupt decompression of the ventricles and collapse of the cortical mantle. And the lesser path of resistance, that it's obviously up through the big hole that you pierced in the cortex and not through the stoma. Sometimes these collections can be complicated with hematomas that you sometimes have to drain. Sometimes you have to place subdural shunting. And very important, look at this. This is a paper that just came out describing neurocognitive complications. And 1 week ago, Henry was telling us about the removal of cysts in the foramen of Monroe, and these are the ones, colloid cysts, are the ones who are more related to neurocognitive long-term complications. And this is basically because you're maneuvering in a very tight area, which has to do a lot with memory function. Also, you can, as you're retracting your endoscope, you can see that sometimes you were quite busy working away in the bottom, and now your fornix has been injured. Most of the time, these contusions on the fornix don't lead to many deficits. I think this is something that we have to look at with neurocognitive studies, but most of the patients do well. Also, working from the outside into the inside can be quite challenging, and you have to know your structures. As you have seen, this is the video that I previously presented that was sent to us by Daniel. As you can see here, drilling in the anterior portion of the internal carotid artery, all of a sudden, you can hit the wall of the carotid. In this particular case, they went in, they packed it with a cottonoid patty, and then they placed some muscle over the defect. And I will speed up this for the interest of time. They were really successful in tamponating away using that cottonoid and that muscle. They placed some additional muscle over the defect. And you can see here at the very end that the final angiogram did not show any pseudoaneurysm forming, and the patient did well. So the final words of advice: remember, not because you have an endoscope, you're free to do whatever you want. Always take CSF samples, cultures, and after you have done your procedure, please just leave. Don't start looking around, seeing how great the ventricular cavity is, because that's when problems will happen. And if for whatever reason you have bleeding, please do not move. Irrigate and irrigate. Most of the time, irrigation is your big helper. And of course, the best way to avoid complications is by listening to all of this experience, not only through webinars, but firsthand in all the webinars that we have worldwide. There's many good surgeons who will share their knowledge with you, and that hopefully that will prevent complications worldwide as we pool all our knowledge and past experience with not only good, but also bad outcomes. And with this, I would like to thank everyone far and near from watching and being patient with us. So I don't know if you have any comments.
Thank you, Adrian. That was brilliant. I think an excellent talk. We've had so much feedback throughout your talk that everybody was very impressed. And the way you've shown it from top to bottom, I think it matched Sandi's talk, and I think it's wonderful to have you speak here on this. Henry, would you like to take it away?
Yeah, I think both speakers for the nice presentations. It's very nice, and we should have a lot of discussions because they raised a lot of points. And I don't know how much time do we have, Salman?
The problem is we have Chandrashekar Deopujari has got 2 cases to show, so we can take, maybe we can have discussion for 5 minutes or 7 minutes, something like that.
Yeah, I'm not sure I understand. Yeah. So the first thing is about what Sandi raised the question: is it a different procedure if we use a rigid scope or a flexible scope? I don't think so. It's just a different technique, but I think the operation is the same. We create a hole or we remove a colloid cyst. It doesn't matter what you use. And when we start with endoscopy, we had the same problem with which was already mentioned here, that we have very poor fiber scopes. So there were a lot of pixels, the quality was very bad, and that's why it was abandoned, and we switched to the rigid scopes, which have better quality in the optics, and also the guidance is much more easier than the flexible scope. But nowadays with the chip on the tip video scopes, it's a brilliant quality. And of course, the flexible scope has a lot of advantages in the treatment of hydrocephalus. We have the problem in Germany that we get no CE approval because these flexible video scopes are not autoclavable. And that's why they are forbidden, because of prion, of the prions, which might be transfected with the scopes if they are not autoclavable. That's a problem. So we cannot use it in Germany. It's very pity. But Tandy, what do you think? I think it's the same procedure, just a different surgical technique. Huh? No comments?
Chandra, would you like to give a comment?
No, I think this has been an excellent talk. Several situations which can be encountered, and I do agree that being a little adventurous, I mean, Sandi showed some cases where the perforation of the third ventricle, I would have thought was extremely difficult. So I think everybody has to watch enough, everybody has to learn enough before they would try to do something like that, and the correct equipment if they have. So I think there are lessons which we have learned from both the talks today.
Chandra, you look good. Really like quarantine.
No, locked in, as you can.
Shlomi logged in a little while ago. I'm not sure. I don't see his name here, but he said, "Oh, great, so many people listening." So yeah. I don't know what happened then. Maybe we have any question. People can raise their hands and we can open their mic up.
If I might say something,
yeah,
if
sure,
I might say
Adrian.
something beforehand,
Adrian,
is that I would really, really, really like to thank all the other members of IFNE who contributed with their videos of complications. We as surgeons have a very short memory, and we always like to show our nice cases. And I think that's something that should be highly commendable, that you should always keep in mind your bad outcomes, you should always have your videos to look back and learn from them and learn to avoid mistakes, and always keep that caseload, keep all those side notes, because that is what eventually will prevent problems in the future. And of course, mentoring is highly commendable with your trainees. Always be there, always tell them, now it's time to stop, now it's time to go away. There's no shame in stopping a procedure and converting this to a shunt. Some of these cases can be disasters, and some of these patients can actually die. So I really would like to, it's highly commendable that a lot of people from the community came forward and said, hey, listen, this is the video of some other surgeon said, this is my worst nightmare, but I'm handing it over to you so everybody can learn from it.
I completely agree, Adrián. The most important thing is complications avoidance, and be ready how to deal with it. That's why this is extremely important. And every case has to be planned according to the individual anatomy, as it's very important that you stressed, we have to look at the MRI, and you have shown so many cases where you could predict some of the problems when you look precisely at the MRI. And I was an expert witness in many lawsuits, and this was a major mistake. People did not look at the MRIs. They didn't realize that the foramen is much, much smaller than the scopes they used to enter the third ventricle. I think you are commended for this topic, very important. Thank you.
Sandi, you want to say something?
Yes, sorry, I was muted by the host before. I thought you were trying to send me a message. Yeah, no, it's I've learned from everybody, the international community, and really I have to thank all of you. My own practice has evolved over the past decade, and the way that I do endoscopy is completely different than the way that I learned it. So I think there's a lot of richness in going to courses and interacting and sharing cases with each other. And really, I would say probably most of those cases that I showed, I would not have done. I probably would have looked at the floor of the third ventricle and thought, I should probably put in a shunt. And when I in fellowship, we would look at neurofibromatosis cases endoscopically, but prep for a shunt and most likely put in a shunt. And I would say probably a lot of the myelomeningocele cases, before I started operating a lot in sub-Saharan Africa, I would have shunted as well. So I got just more and more facile over time. And the flexible endoscope, I was not a believer at first. So there were a few tricks that really changed the way that I view it. And Henry, I think there are huge limitations in the flexible endoscope in terms of the working channel. The working channel is just very small. And also when you are very deep, already kind of positioned in a strange place, you can't really put in the forceps, like the biopsy forceps and things. When I was at the bottom of the fourth ventricle, I could have made a bigger hole if I could put in a bigger instrument, but I didn't think that I wanted to do that and risk anything by forcing the instrument down the working channel of the flexible endoscope, which was why I thought the Fogarty would be flexible and I could sneak that in. So I think really, Adrián, as you said, kind of having that judgment call and always having in the back of your mind that you are one movement away from something that can be irreversible for the patient. I'm very cognizant of that, but I mean, I've learned from you all, but there are limitations for the flexible endoscope, but for certain things like hydrocephalus, it's been amazing. But complex hydrocephalus is very, the scan will make it look like it's going to be really easy, but when you're in there, it's very easy to get disoriented. So I think for those, I would say, neuronavigation and also more the augmented reality and the new technologies coming are going to be really important. But don't be fooled by the scan looking like it's going to be easy. The anatomy always has to make sense.
So I see that Shlomi here is within the audience. So Shlomi has always been a good guru for
Let's see if we
always
can.
a lot of advice. So perhaps Shlomi would like to.
What's has he got any name there? Because I'm seeing with Shlomi, I can't get it here. Yeah,
Shlomi perhaps can make a comment, and I highly commend you to read this paper that was recently published by Shlomi. I think this is something that's very worth reading. Jonathan and Shlomi have done a great job. I think Shlomi cannot hear us, or is he muted?
What's the name there that he's got? Because I don't have anybody by the name of Shlomi here.
It's like S. Constantini. S. Const.
Oh, S. Constantini. Okay, let's see.
There you go.
Okay, here we are.
Oh, good. Do you hear me?
Yes.
Yep.
Yes, thank you very much. Excellent talks. I like the joke that following neuroendoscopy, the patient is well and can go to the ward, but the neurosurgeon needs an ICU himself. And only those of us who do it know how diverse it is and how you encounter problems. If I had to choose one advice out of the many that you heard, is to have a competent helper with you. It is so nice to have, not only for the maneuverability of an introduction of working tools, but also for the discussion of when to abort, as was mentioned here. Because this is an ongoing discussion, and sometimes when I work with Jonathan Roth, I urge him to stop, he urges me to stop. I think it refines the risk to benefit ratio, which is an issue always with this delicate procedure.
Correct.
Okay, excellent. Any more takers? Otherwise, Chandra, can we do one case maybe?
Okay, so I'll do a quick case just to show you how we can use endoscope assisted surgery for removal of tumor. I would I think
need to screen share again.
Okay, so this is a 25-year-old lady who's actually come with chronic headaches to us, and she actually came eventually when she started having visual blurring. And this is the scan. You can see
we don't see the scan. Please show it.
Chandra, sorry, we are seeing just the files, but we're not seeing the scan. So we're not seeing the PowerPoint presentation. So maybe if you have it in front, then maybe come out of it and then share it again.
Can you see it now?
No, that's what I'm saying. If you just stop sharing the screen, if you go on the top, yeah, and now.
Now?
No, it's okay. Now we can see it. Great.
Okay. So you can see a lot of turbulent flow, and you can see an irregular lesion in the posterior third ventricle. Further image. I am unable to move the. Okay. So you have a diffusion weighted image, which you can see that you have most likely epidermoid here in the pineal region, and maybe Henry is on the screen anyway. How would you like to tackle this?
Can you show us again an axial view?
Yeah, I'll show you one more view.
But this could be an infantile supracerebellar, or it could be an interhemispheric transtentorial.
Would you do it endoscopic at all?
No, I usually do endoscope assistance in these cases.
Right. So this is what we actually did. As you can see, we did a supracerebellar infratentorial approach. This is the head end. This is the posterior fossa. The cerebellum is being gently retracted down, and you'll see that we don't want to retract too much because of the paracentral vein over here, and we try to get gradually to the epidermoid and start removing it. You can start seeing a couple of other bridging veins, and between the two veins we find a corridor to remove this, and all this is usually done without putting a retractor. The dynamic retraction by your suction and forceps alone is usually good enough, because that is the main worry which you have when you operate in this area. And as you can see that it is not, it is getting decompressed quite well, though the vision is not great. And this is the time we think we need to probably use endoscopic assistance, as Henry just suggested. You can see that the scope is being inserted now, and with that you can use the scope also as a retractor, and it can be gently dissected. I think this is possible to do with many soft tumors, and especially epidermoid is ideally an ideal lesion which can be gently sucked away if you have good enough patience. And you will find that this is the last bit which is obstructing the aqueduct, which has now been taken out, and you can see a free CSF flow. So this turned out to be a very good approach, and we were able to take this lesion out completely. We did not have to do a third ventriculostomy because the patient was already shunted before the patient was sent to us, and we would probably take it out when the patient comes back. So I think a short case to probably end the session today. Any suggestions?
Very, very well done, Chandra. It was a nice case and a good approach. We would have chosen the same. I think a pure endoscopic resection makes no sense. In my hands, I don't see any advantage. Of course, you can do it, but I think the combination of the microscope, especially in the initial phase of the surgery, when you have no space between the tent and the cerebellar surface, then it is much better you go with a microscope, in my opinion. Very well done.
Would you, if the ventricles were a little larger, would you consider doing a ETV and trying to get at the cyst from the frontal approach itself?
No, I think you have to make the decision before, because the trajectory is completely different. If I have a small tumor and I think I will be able to get a total tumor resection with restoration of the aqueduct, I would come from an anterior approach directly to the aqueduct entrance. But if I'm in doubt, I would make an ETV, and then I would come from this approach what you have chosen. It depends from the size. If the tumor is too big, I think you are not effective. If it's a smaller one, and of course you can do it. Pepe has shown some nice cases with Akusa when he used it to resect it, but also with grasping forceps. We had a small ependymoma directly in front of the aqueduct. The diameter was just 5 millimeters, but exactly in front of the aqueduct, occluding it, we had large ventricles, and we just resected the tumor without any ETV.
Pepe, you have any comments? I think Pepe is out for another seminar.
He's gone for another seminar. Yeah, he left about 20 minutes ago. Sorry.
Thanks, Salman. I think the next case for some other